All right, guys. Well, this is the last one. Thanks for hanging in there. It's been a lot of information today, like Derek said, but it has been an absolutely awesome day with lots of great information. Don't hesitate to reach out to anyone that spoke today if you have further questions, because it's been a lot of great information. So this morning, we talked about the COVID, the antimicrobial update. Now we're going to be talking about some other information, and this is called Cutting Edge Medications 2020. So the first thing we're going to look at is our objectives. So you can see what we're talking about. Medical cannabis really seems to be on the forefront in Missouri. Once it got passed, it just seems like it's went pretty bonkers, at least down here in Southwest Missouri. And I've actually talked to a couple of my girlfriends that do mental health, and they say that they have been super, super busy with the mental health patients from this. So let's really kind of look into this, as well as some other new medications that's hit the market, and see how it affects our practices. So first, cannabinoids is a group of substances found in the cannabis plant. The main cannabinoids are THC and cannabidiol. And there are more than 100 other cannabinoids that have been identified. And it's funny because at the first of this year, they said they thought there was 104. And by summer, they had identified 112. So that tells you it's just continuing, and who knows what the end number will be. But there are two active components of cannabis. The THC, which just got legalized in Missouri for medical, activates cannabinoid receptors in the brain, which causes the high. The CBD works on different receptor sites, so they don't get the high. And the best known species of cannabis is the cannabis indica and the cannabis sativa. And for those that was not at the conference last year, we had a really good speaker that gave a pretty in-depth talk about medical marijuana. But again, because it is so important, I really did want to touch on it this year. But really, the big thing to remember is the product chemical profile is really more important than the strain of the plant from which it originated. And products really will be categorized by analytical chemistry, which is the percentages of cannabinoids and terpenoids. Now, I have not been in a dispensary. There may be some of you that is, so if I'm saying anything incorrect about the dispensary, please correct me. But once it gets to the dispensary and your patient gets their medical cannabis card, they go to the dispensary. There are hundreds of different things to choose from, different names, but they all go back to the indica or the sativa, but then they have different strains for those. So on the CBD, it is the second most prevalent of the active ingredients in cannabis. This is directly derived from hemp, and it's a single ingredient, and it does work on those different receptors, so they don't get the high. It's non-FDA approved, and the side effects are nausea, fatigue, and irritability. And we do see lots of interactions with our coumadins and statins. The CBD is non-prescription, and my biggest hang up with CBD is there's no regulation. So you may be getting your patient may get one thing that has a super large amount of CBD and one that may not. So just be aware of that. They can have inconsistent formulations and contaminants. as far as the FDA guidelines, even though we have approved in Missouri the medical cannabis, the FDA has not approved the cannabis plant. There are several medicines from cannabinoids ingredients that we have approved. The Epidiolex, which contains a purified form of CBD derived from cannabis, and this was approved for treatments of seizures associated with Lennox-Gastaut syndrome or Dravet syndrome. And these are basically two really rare and serious forms of epilepsy, Marinol and Syndrose. You know, Marinol, I remember giving it as an LPN in the mid-90s, but Marinol was still around, Syndrose, and these are synthetic, and they're approved by the FDA, and they're used to treat nausea and vomiting caused by cancer. And it's also used to treat loss of appetite and weight loss in people with HIV and AIDS. The ones that I've seen Marinol treated in was a lot of paraplegics that were very thin and didn't want to eat. So lots of uses. We have multiple different ways that you can take medical cannabis. You can have the inhalation, which is where they smoke, the resin, the concentrate, oral, which is the prescription, the tinctures, the edibles. I believe someone said earlier about the gummies, oral mucosa or sublingual. They've actually got lollipops and lozenges. Topical or rectal is herbal cannabis, resins, concentrates. And so remember, however they're taking it really does affect how much is in their bloodstream and how much effect they have on their body. If you remember from your rectum, there's lots and lots of blood vessels, so you actually do absorb a lot more. So if you've got that patient in the office, just remember those types of things. So the mechanism of action, the CBD and THC are both metabolized by the CYP-P450 enzyme, specifically the CYP3A4 and the CYP2C9. So just remember that meds that cause these enzymes can increase CBD and THC, but it slows down the metabolism and it can increase the effect of the drug. And meds that increase or induce these enzymes could decrease CBD and THC levels, which is going to speed up your metabolism or decrease the effect of the drug. On another note, CBD, but not THC, is metabolized by your CYP2C19 enzyme. So why is this important? Well, if you remember, your CYP3A4 enzymes are responsible for over 50% of metabolism of medication. The small intestines have the highest CYP3A4 activity, and you can have interactions due to intestinal rather than hepatic enzyme inhibition. So THC is a CYP1A2 inducer. So theoretically, THC can decrease serum concentrations of clonazepine, duoxetine, naproxen, cyclobenzaprine, olanzapine, haloperidol, and chlorpromazine, whereas your CBD is a potent inhibitor of CYP3A4 and CYP2D6. So as CYP3A4 metabolizes the medication, CBD may increase serum concentration of macrolides, calcium channel blockers, benzodiazepines, cyclosporin, sildenafil, and all your PDE5 inhibitors, antihistamines, haloperidol, antiretrovirals, and some statins. And I did find it interesting on the statins that it affects is affected by atorvastatin and simvastatin, but not the pravastatin or rosuvastatin. And the CYP2D6 metabolizes many antidepressants. So CBD may increase serum concentration of SSRIs, tricyclic antidepressants, antipsychotics, beta blockers, and opioids. And this does include codeine and oxycodone. So when you look at this list, whether it's an inducer or an inhibitor, you've got patients on almost every one of these medications. So, and a lot of times because CBD isn't prescription, they may not even tell you that they're taking it. So it is really super important to be able to, you know, have that honest and open relationship with that patient that's non-judgmental, that they feel comfortable confiding in you and telling you what they're taking so that you can verify and make sure that they're not on Viagra or not on atorvastatin that can potentially cause them some issues. So there's been lots of drug interaction studies. THC and CBD increase warfarin levels. Frequent cannabis has been associated with increased INRs. Alcohol increases THC levels. Smoked cannabis can decrease theophylline levels. No real effect on indovinir and nelstanavir, and cannabis tea didn't have a lot of effects as well. So very interesting. You know, I could completely see where alcohol could increase those THC levels, but I'm going to go over some stuff in a minute that really is hard for me to wrap my mind around. So CBD increases clobazam levels in children with epilepsy. And on CNS depressants, cannabis has additive CNS depressant effects with alcohol, like we talked a minute ago, barbiturates, and benzos. A small study said that cannabis did not have additive CNS effects when combined with opioids. Now, granted, that is a small study. That one is the one that's really difficult for me to wrap my head around, because you would think, especially if they're taking the strain of cannabis that relaxes, that it would have an additive effect. So I'll be interested to see how that comes out, you know, in the next couple of years. I think we'll see some differences in that. So what does this mean for you? Again, oh, and that says CBC, but that's supposed to be CBD. My apologies. Again, the big CBD is not illegal. It is a very legal over-the-counter medication that probably a lot of your patients are taking unless they're pediatric. Just remember that you have a lot of medications that can either increase or decrease. So this one here is a list of some inhibitors of CYP3A4, which is your clarithromycin, erythromycin, diltiazem for your heart, your antifungals, your antivirals, another verapamil, a heart medicine, golden seal, which is an herb, and grapefruit. So consider reducing those CBD doses. So if your patient tells you that they're taking CBD, you need to tell them, you know, we really need to kind of back off of that whenever they're on moderate to strong inhibitors. Or maybe it's a dietary, the grapefruit. Maybe you just need to advise them that they really shouldn't eat grapefruit. The potent inducers of CYP3A4 is your phenobarbital, your phenytoin, your rifampin, your St. John's wort, your carbazepine, and glucocorticoids. And so you really need to monitor for a need to increase CBD doses when used with inducers, which again is kind of different, because I would think that it would cause additive effects instead of needing to increase the dose. So just be aware of that and know which way the pendulum is going so that you can do the best for your patient. So in review of CBD, meds that can increase CBD levels, macrolides, so your antibiotics, omeprazole, which a lot of people may not even tell you that they're taking because they get it over the counter. Your calcium channel blockers, your antifungals, your warfarin and Plavix, your amitriptyline, morphine, carbazepine, phenytoin, valproic acid, Flexeril, citalopram, and bupropion. So all of these things can increase your CBD level. So just be aware of that. Foods that can increase it: grapefruit, high fat, high calorie foods, golden seal, which we talked about a minute ago. It's crazy how a lot of these herbs do have some of those cross contaminants, and I usually tell my patients that herbs is no different than medication. It's just one that's not prescribed, but that I do need to know which every single one of them are. Meds that decrease the CBD levels: phenobarb, phenytoin, carbazepine, rifampin, glucocorticoids, and St. John's wort. Drugs that may increase: and alcohol, benzos, and opioids. And I put this opioids on this slide because I still, even though the small study said that it can decrease, I have seen too much in my clinical practice where it has increased. So just be aware of that. Common adverse effects. We've all had the patient that came in with either CBD or THC. They can suffer from anxiety, reduced tear flow, which causes the red eyes, the decreased eye blink, the slow papillary response to light, changes in visual perception, dry mouth, chronic bronchitis, vertigo, reduced coordination, and decreased sperm count, which is a big one with the guys. Contraindications to medical cannabis. Absolute contraindications are acute psychosis and other unstable psych conditions. And relative contraindications are severe CAD, coronary artery disease, immunological, liver, or kidney disease. And cannabis may exacerbate arrhythmias or history of arrhythmias. So lots and lots there about the medical cannabis. But, we've got a lot of patients that's really started doing the medical cannabis and the CBD. So it's important for us to understand and be able to treat our patients appropriately. So we do have some labeling changes on meds in 2020. Most of your ADHD meds now have the National Pregnancy Registry of ADHD meds added to the label, and this is true on the clonidine, the Strattera, Focalin, and Mydayis. And I would be really happy someday if as NPs that we could prescribe some of these. I know we can't Strattera and clonidine, but the Focalin and Mydayis. So Derek, that's your assignment. Hepatitis C treatment, they've had some changes, and a lot of this has been the medications that they've already approved, but they've had such good luck with it that they have expanded the ages for it. So like your Mavinet for chronic hep C, these are only for genotypes 1 through 6 infections, and they expanded the indication to age 12 and older or weighing at least 45 kilograms. And this was previously only approved for adults. So to me, this one is super exciting because I know that they've had a lot of good results with adults, and to be able to have one for kids that may not be quite so hard on their systems. Sovaldi for chronic hep C, and that's for Geno 1 or 4, and they've expanded this age range down to 3, which is cool. Then Harvoni, which is your chronic hep C geno 1, 4, 5, or 6. And they've also expanded this down to age 3 or at least 17 kilograms. So again, really opened up those treatment options for your kiddos that may have hep C. Cystic fibrosis, there's a new medication that's been approved for that, and that's your Trikafta, and it has 3 different medications here, and it's approved for 12 years or older for patients with cystic fibrosis who have at least one F508del mutation in the CF transmembrane conductor regulatory gene. So not all cystic fibrosis, they have to have that one specific mutation to get this medication. But it does increase, predicted the percentage of your FEV1, which is really nice. And then, but your CFTR gene is estimated to be present in about 90% of the cystic fibrosis population. So even though you need to make sure it is the one specific mutation, 90% of your CF patients are going to have this. Sickle cell disease. I really thought this was really neat. Oxbryta, I'm probably not saying that correctly. This has been approved down to age 12. And this is an inhibitor of the deoxygenated sickle hemoglobin polymerization. So what this does is, you know, your sickle cells are sickle in shape. That's where the name came from. They're less likely to bind together and form that sickle shape. It did go through an accelerated approval through the FDA, and further trials are ongoing. But this looks really cool that these kiddos may really benefit from this. Okay, Duchenne muscular dystrophy. We've got VONDIS 53 injections, and this is treatment. Again, it's an injection, but they have to have a confirmed mutation of the gene that is amendable to the exon 53 skipping. So basically, VONDIS 53 masks the exon 53 in the messenger RNA of the DMD gene, so that protein synthesis machinery can skip the exon and piece together the remaining exons to make small but functional dystrophin proteins. So the original trials are looking very, very good for this as well. They did give it an accelerated approval as well, and they've got some further trials ongoing. Changes in medication. Benlysta IV infusion. This is for your SLE, but it is now, we've already had that out for adults, but now you're going to be able to go down to ages 5 through 17 years. Your Nucala sub-Q injection. This was added on maintenance treatment of patients with severe asthma, 6 years and older, but it has to be the kind that has the eosinophilic phenotype. So not all your asthma patients, but at least it does go down to 6 years of age. Dupixent sub-Q injection, that has recently gained a new approval, and that is approved for ages 12 and up for moderate to severe dermatitis. And then this sounds very strange, but you know, last year at our conference, we really talked a lot about monoclonal antibodies and stem cells. And so it was approved that all the monoclonal antibodies is going to have the stem MOB on them. So when you see MOB, you know it's going to be a monoclonal antibiotic. The Beers criteria did have some change in their guidelines. For those of you that don't know what the Beers criteria is, it is a unique set of evidence-based practices tailored specifically for the older adult at 65 years and older. It's in all care settings except for hospice or palliative care. And these list of potentially inappropriate medicines, which we call PIMS, provide guidance on how to optimize medication selection in older adults, and it can help meet a variety of healthcare needs. You know, you really have to remember that older adults respond differently than younger adults to medication due to changes in medication absorption, distribution, metabolism, and elimination that occur over time. And I know Dr. Franklin spoke about that this morning, which fits right hand in hand with this. But older adults can also have more or less sensitivity to medications, and these unpredictable age-related changes often increase risk for adverse effects and drug interactions. So really, to help navigate these challenges, the Beers Criteria Panel evaluates controlled clinical trials, observational studies, systematic reviews, and meta-analysis with a special emphasis on adverse drug effects or reactions to update its recommendations. Really, you need to think of the Beers criteria as a warning light to help identify potentially inappropriate medicines, and medication decisions should be individualized and based on shared decision making between you and the patient, risk versus benefits. So the update in 2019, your trimethoprim sulfamethoxazole, which is your Bactrim DS, should be used with caution. You know, we already were using for caution, but they added on if this is combined with a angiotensin converting enzyme inhibitor, so an ACE inhibitor or an ARB, in patients with decreased creatinine clearance. These patients have a huge risk for hyperkalemia. So you definitely, you know, don't want to give this in the elderly patient if they're on an ACE and an ARB. You need to avoid prescribing warfarin when patients are taking antibiotics such as ciprofloxacin or macrolides, except for azithromycin or Bactrim when possible due to an increased bleeding risk. The INR should be monitored closely if warfarin is used concurrently with any of the antibiotics. And 2 clinically important opioid interactions were added to the criteria in 2019, which are particularly relevant as opioid-related deaths in older adults have increased over the last couple of years. The combination of opioids and benzos should generally be avoided due to the increased risk of overdose. The recommendation found that benzo use in the U.S. tends to increase with age, particularly women. So you really need to try to avoid that or deprescribe. The combination of opioids and I'm not going to say this right, penoids, which is also your gabapentin and pregabalin, should generally be avoided due to an increased risk of sedation, respiratory depression, and potentially death. The recommendation excludes when switching from an opioid to a gabapenoid. In 2015, protein pump inhibitors were added to the Beers criteria PIM list to generally avoid for long-term use in older adults unless a patient is really high risk. Because H2 receptor antagonists were also on the PIM list to avoid in patients with dementia or cognitive impairment due to potentially adverse cognitive effects. So really, I know a lot of you guys, you think, well, I can't give them an H2. I can't give them a PPI, so what am I going to do? So you really have to look at the lesser of 2 evils, and you have to do what's best, risk versus benefits with your patient. But due to weak evidence on the H2 receptor antagonists, they were removed from the PIM list to avoid in patients with dementia or cognitive impairment, but they are still PIMs to avoid in patients who are high risk for delirium. SNRIs were added to PIMs to avoid in older adults with a history of falls or fractures unless alternatives are unavailable. The recommendation is due to an increased risk of unsteadiness, syncope, and additional falls. And it also applies to SSRI and tricyclic antibiotics. or tricyclic antidepressants. This recommendation helps improve and emphasize the importance of the old motto, start low and go slow. So just be careful if you're giving one of these medications and are older adults with a history of fall. I know a lot of them are depressed. So again, risk versus benefit. Tramadol was added to the list of PIMs to use with caution in older adults due to an increased risk of hyponatremia or SIADH. Sodium levels should be monitored with medication initiation and adjustments, especially if the patient is on antidiuretics, SNRIs, or SSRIs. And last but not least is aspirin. The criteria previously recommended to use caution when using aspirin for primary prevention of cardiovascular disease in people 80 and older. They took this age down now to 70 years of age or older. Recent studies, though, have shown that no significant difference is in primary prevention of cardiovascular disease versus people that were on aspirin versus not on aspirin. And since it has the increased risk of bleeding, that's why they added it to the PIM all the way down to age 70. And here's our MABs, monoclonal antibodies. And these are really cool. I know we kind of talked about it last year at the conference, but for those that were not there, the FDA has really said this is not a medicine, it's not a generic, it's a biologic, and it's an exact copy that has a monovalent affinity. So what that basically means is they're antibodies that are made by identical immune cells, which are all clones belonging to a unique parent cell. And these MABs can have where they bind to the same epitope. So they are specific and go to exactly where they need. MABs are used to treat many diseases, including some types of cancer. To make a MAB, researchers had to identify the right antigen to attack. Finding the right antigen for cancer wasn't always easy, and so far some MABs have been more useful than others. Some monoclonal antibodies used to treat cancer are referred to as targeted therapy because they have a specific target on a cancer cell that they aim to fight, attack, and attach to and attack. But other MABs act more like immunotherapy because they make the immune system respond better to allow the body to fight and attack cancer cells more effectively. We have naked MABs, and these are antibodies that have no drug or radioactive material attached to them. They really work more by themselves. They are the most common type of MABs used to treat cancer, but they attach to antigens on cancer cells, but some work by binding to antigens on other non-cancerous cells or even free-floating proteins. So really your naked MABs can work in several different ways. Some boost the immune response. Some work to destroy the cancer cell. Conjugated MABs, they are combined with a chemotherapy drug or a radioactive particle. These MABs are used as a homing device to take one of these substances directly to the cancer cells. The MAB circulates throughout the body until it can find and hook onto the targeted antigen. It then delivers the toxic substance where it's needed most. This lessens the damage to normal cells to other parts of the body. And I think that's really cool that they're able to do that. Bispecific MABs, and these drugs are made up of two parts of different MABs, meaning they can attach to two different proteins at the same time. An example is Blincyto, which is used to treat leukemia. One part attaches to the CD19 protein, which is found on leukemia and lymphoma cells, but the other part attaches to the CD3, which is a protein found on immune cells called T cells. And so by binding to both of these proteins, The drug brings the cancer cells and immune cells together, which is thought to cause the immune system to attack the cancer cells. And the last one that I don't have on here is radio-labeled antibodies, and they have a small radioactive particle attached to them. An example is Zevalin, and it has an antibody against the CD20 antigen, which is found on lymphocytes called B cells. And the antibody delivers radioactivity directly to the cancer cells. Really cool because it can be made up of different medicines. MAB side effects. Monoclonal antibodies are given IV. The antibodies themselves are proteins, so giving them can sometimes cause a little bit of an allergic reaction. This is more common when the drug is first being given. And so the side effects that you can typically see is fever, chills, weakness, headaches, nausea, vomiting, diarrhea, hypotension, and rashes. Infliximab, this is a mAb that targets specific TNF alpha. It attaches to the cytokine that generates inflammation and disrupts the ability to produce inflammation. And we see new indications for this for irritable bowel disease, rheumatoid arthritis, psoriasis, again, because it helps disrupt that inflammation, and these are inflammatory disorders. Denosumab is a mAb that targets rankle. And so the mAb attaches to protein that inhibits osteoclast survival, so bone reabsorption is decreased. So we see this now indicated in the treatment of osteoporosis. I am not even going to try to say this one, but it is a mAb that targets cells that overexpress HER2. So we really see this in, because it inhibits Beth asked, did the FDA approve these? So is insurance now covering these? No, the FDA did not approve them, but they are allowing them for certain indications. So insurances probably are not covering them at this point, but the studies that are coming out are absolutely amazing, Beth. And so I really think in the next 2 to 5 years, we're going to see insurances pay for these because they're so much more effective than the drugs we were using. They have less side effects, and they have a huge percentage of patients doing better. But this particular one, it inhibits the proliferation of human tumor cells that overexpress HER2. And if you remember, the HER2 is your breast cancer for women that's hormone positive. So, really, the future's so bright, you got to wear shades. I love this. Hundreds of mAbs are being developed. They're being developed for autoimmune, respiratory, neurology, thyroid, musculoskeletal. I really think this is where we are going to see the future of medicine or healthcare going. And last but not least, I did throw this last slide in here for medication shortages. I've had a lot of people say, why don't we just make more medicines? And, it really is a multifactorial issue, but there's really decreased revenue and incentives to produce cheaper meds. The logistical and regulatory challenges make it difficult for markets to recover from a disruption, for instance, with COVID. And the market does not recognize and reward manufacturers for mature quality systems that focus on QI and early detection of chain supply issues. So I know this really is completely different than mAb, but because of COVID and a lot of the medication shortages that we're experiencing, I think it's important to really discuss that and look at that. And those of you that are interested in health policy and are lobbyists on federal levels and things. Those are some of the things, your senators, that we need to be contacting to fix that, because it's just absolutely unacceptable. Now, any questions about any of that I have provided?
Shanna,
All right.
Shanna, this is Lila. I remember last year they said that the CBD products most of them couldn't guarantee to be 100% pure. Therefore, sometimes they showed up on drug tests. So somebody gave an example of her husband who was a truck driver and who was using CBD products for his muscle pain from driving, and it was identified as THC on a drug test. Have you heard anything more about that?
I've been personally told that CBD is not supposed to show up on drug screens. I have had multiple patients swear up and down that they're not taking actual cannabis, that it is CBD. It's hard for me to say. The literature says that it can't, but I will tell you, I see it a lot.
Well, I know they said last year that they couldn't say that that no matter what the company said, they couldn't. Few of them could say, if any, could say that it was pure.
Mm-hmm.
And I
I'd
know
be interested. Oh, go ahead.
No, okay. So I guess we need to look up more information on that, because if it's something that could show up on a drug test, it's not only important for people like truck drivers, but it'd be important for professional people.
I agree completely.
Like persons who can get drug tested.
Derek, is the lady that did the SMART presentation in the room? I'd like to hear her opinion of that, if she is.
Yes, she is. Hang on just a second. I'll take the mic back to her. If there was somebody else that was commenting on that. Patty, did you have something to say on that? Patty, do you have something to say on that? No. I know it can. You know it can? Okay. Hang on just a sec.
So I know that this can happen. The Federal Drug Administration does not approve it, but according to the Farm Bill that was passed in 2018, per section 10113, CBD can be pure with hemp and can contain up to 0.3% THC. And if you were talking earlier about those medications that can enhance CBD, then it can definitely show up as a positive THC. The drug screens that they do are only a positive or negative. It doesn't say how much. And I can attest to this because my husband used CBD and he failed a drug screen, and he does not smoke or ingest any marijuana products. And so I did my research on it. And so most of the products that say pure hemp, then they can contain 0.3%. Did you hear all that? I'm sorry.
We did. No, thank you for sharing.
That's really good to know.
And, you know, he was talking about a positive versus negative drug screen, and they do have cutoff levels. And so she's exactly right. If you're taking something that's going to increase your level, that's liable to put you over that positive level. So thank you very much for sharing.
Hang on just a second. They won't be able to hear you. You go.
A lot of those drug screens they're doing through those OC Health drug screens for starting employment, they don't have that specific level. And so if any of the metabolite of THC shows up at all, it's going to trigger a positive.
I think my clinic is 400. And we have those dipsticks that just do that for occupational health. But if they're less than 400, it doesn't show up. If it's over 400, it does.
Okay. Suzanne Opperman, who did the SMART recovery, is God has the microphone now, Shanna, if you wanted to ask a question about that.
No, I just wanted to hear what her opinion was on the drug screens in general.
Well, there's no standard for the drug screens as to what company uses what screen, what people are getting over the internet, like through Amazon. So there's no standard for testing. And like you said, some of them, have a cutoff. Many of them do not. It's just simply positive or negative. And my real concern is with medical marijuana, there is no guarantee as to the purity of that either. So people are showing up with positive fentanyl, positive meth, just a number of different things. So you can't really make a blanket statement because not everybody's using the same standard.
That makes sense. Can I ask you one more question?
Sure.
On medical cannabis, when they buy the edibles, is the dispensary making that?
Again, it varies. It depends upon their sources of what they get. A lot of it comes through the mail, like from California and Colorado. And again, there is no standard. These different facilities are not tested for the purity of their substances nor their resources. Many of them are growing their own, which makes it much safer, but it just depends upon the source. And since it's not FDA regulated, there is no consistency.
That makes sense. Thank you.
Edibles are much less likely to be contaminated, but again, no guarantee.
There was a question from Beth DeHaven. Said, did you say the FDA did approve these? So if so, is insurance now covering these?
I actually answered that while I was speaking.
Oh, sorry about that. I wasn't in here when you did. Okay. I think that is all. Is there anybody in here that has a question for Shanna? Okay. I think that's it. Thank you, Shanna, very much for your second presentation. We appreciate that.